Hello again. Welcome back. This is Mike. Today, we'll continue our discussion on respiratory disorders, diagnosis, management, and prevention. We will have a short review of the anatomy and physiology of the respiratory tract. Let's now discuss the gross anatomy of the respiratory tract. They include 1. The pleura, 2. The lungs, 3. The blood and lymphatic supply, and lastly, the innervation. The pleura is a thin serous membrane that consists of a parietal pleura and a visceral pleura. Parietal pleura is the layer of serous mesothelium that lines the inner surface of the thoracic wall and the mediastinum and is very sensitive to pain. The costal pleura lines the thoracic wall. The diaphragmatic pleura lines the thoracic surface of the diaphragm. And lastly, the mediastinal pleura lines the mediastinum and sides of the pericardial cavity. Now, the visceral pleura intimately invests the lung and dips into all the fissures with blood supplied by bronchial arteries and drained by pulmonary veins. It is insensitive to pain, but is sensitive to stretch and contains vasomotor fibers and sensory endings of vagal origins, which may be involved in respiratory reflexes. The pulmonary ligament is a two-layered vertical fold of mediastinal pleura that supports the lungs in the pleural sac by retaining the lower part of the lungs in position. Now, the pleural cavity is a potential space between the parietal and visceral pleura. The costodiaphragmatic recesses are the pleural recesses formed by the reflection of the costal and diaphragmatic pleura. Now, the costomediastinal recesses are part of the pleural cavity where the costal and mediastinal pleura meet. Next are the lungs. They are the essential organs of respiration and are attached to the heart and trachea by their roots and the pulmonary ligaments. They have bases that rest on the convex surface of the diaphragm, descends during inspiration, and ascends during expiration. Parasympathetic fibers innervate smooth muscle and glands of the bronchial tree, which are excitatory to these structures, both bronchoconstriction and secretomotor. Sympathetic fibers innervate blood vessels, smooth muscles, and glands of the bronchial tree, which are inhibitory to this structure, or bronchodilators and vasoconstrictors. Lastly, stretching of the lung during inspiration stimulates sensory endings of vagal origin and are concerned in the reflex control of respiration. The structure of the lungs includes the lobes, bronchopulmonary segments, and the airways. The lobes are composed of the right lung, which is an upper, middle, and lower lobe, and the left lung, which is an upper and lower lobe. The bronchopulmonary segment is the anatomic, functional, and surgical unit of the lungs. They consist of a segmental bronchus centrally, either tertiary or lobular, a segmental branch of the pulmonary artery, and a segment of the lung tissue surrounded by a delicate connective tissue septum called the intersegmental septum. They are clinically important because the intersegmental pulmonary veins form surgical landmarks, and thus a surgeon can remove a bronchopulmonary segment without seriously disrupting the surrounding lung tissue and major blood vessels. The conducting portion of the airways includes the nasal cavity, nasopharynx, larynx, trachea, bronchi, bronchioles, which possess no cartilage, and terminal bronchioles. The respiratory portion includes the respiratory bronchioles, alveolar ducts, the atria, and the alveolar sacs. Oxygen and carbon dioxide exchange takes place across the wall called the blood-air barrier of the lung alveoli and pulmonary capillaries. The blood and lymphatic supply includes the pulmonary vessels, the bronchial vessels, and the lymphatic vessels. The pulmonary vessels includes 1. The pulmonary trunk, which arises from the conus arteriosus of the right ventricle of the heart and carries poorly oxygenated blood to the lungs for oxygenation with much lower blood pressure than that in the aorta and is contained within the fibrous pericardium. They include a right pulmonary artery and a left pulmonary artery which is connected to the arch of the aorta by the ligamentum arteriosum, the fibrous remains of the ductus arteriosus. Next are the pulmonary veins, which are intersegmental in drainage and carry oxygenated blood from the respiratory part or alveoli of the lung and deoxygenated blood from the visceral pleura and from a part of the bronchioles to the left atrium of the heart. They leave the lungs as 5 pulmonary veins, 1 from each lobe, but only 4 veins enter the left atrium. Next are the bronchial vessels. The bronchial arteries arise from the descending aorta at the level of the trachea's bifurcation, which is around T4 and T5. Usually there is 1 artery for the right lung and 2 for the left lung. They supply oxygenated blood to the non-respiratory conducting tissues of the lungs and the visceral pleura. Anastomosis occur between the capillaries of the bronchial and pulmonary system. Next are the bronchial veins, which receive blood from the bronchi and empty into the azygous vein in the right and into the accessory hemiazygous vein or the superior intercostal vein on the left. They may receive twigs or small vessels from the tracheobronchial lymph nodes. Lastly, the lymphatic vessels. They drain the bronchial tree, pulmonary vessels, and connective tissue septa into the pulmonary or intrapulmonary and bronchopulmonary nodes in the hilum and eventually drain into the thoracic duct on the left and right lymphatic duct on the right. The hilar nodes are often involved in bronchogenic carcinoma. They are not present in the walls of the pulmonary alveoli. Lastly, about pulmonary innervation. First is the pulmonary plexus, which receives afferent and afferent or parasympathetic preganglionic fibers from the vagus nerve with branches, sympathetic postganglionic fibers from the sympathetic trunk and cardiac plexus. It has branches that accompany the blood vessels and bronchi into the lung, sympathetic nerve fibers that dilate the lumina of the bronchi and constrict the pulmonary vessels. Parasympathetic fibers constrict the lumina, dilate the pulmonary vessels, and increase glandular secretion. Excessive stimulation results in asthma. Next, the phrenic nerve, which arises from the 3rd through 5th cervical nerves and lies in front of the anterior scalene muscles. It enters the thorax and is accompanied by the pericardiophrenik vessels, the internal thoracic vessels. It innervates the fibrous pericardium, the mediastinal and diaphragmatic pleura, and the diaphragm for motor and its central tendon for sensory. Now, let's go to the histology or microscopic anatomy of the respiratory tract. First is the pulmonary lobule, which is a cluster of 3 to 5 terminal bronchioles, each with its appended acinine. The lobular architecture is important in distinguishing between types of emphysema. Nearly the whole respiratory tree is lined with pseudostratified tall columnar ciliated epithelial cells heavily admixed in cartilaginous airways with mucus-secreting goblet cells. Only vocal cords are covered with stratified squamous epithelium. Next, let's discuss the blood-to-air interface of the alveolar walls. First is the capillary endothelium, which lines the anastomosing capillaries. Next is the basement membrane and surrounding interstitial tissue, which separates the endothelial cells from the alveolar lining epithelial cells. In the thinner portion, the basement membranes are fused. In the thicker portions, the basement membranes are separated by pulmonary interstitium with elastic fibers, collagen bundles, fibroblast-like interstitial cells, smooth muscle cells, mast cells, lymphocytes, and monocytes. Third, alveolar epithelium is a continuous layer of 2 cell types. First is type 1 pneumocytes, which are flattened, plate-like, covering 95% of the surface. Next are the type 2 pneumocytes, which are rounded, surfactant-producing, and involved in repair after the destruction of type 1 pneumocytes. And lastly, alveolar macrophages. These cells are derived from blood monocytes and are loosely attached to the epithelial cells or lying free in the alveolar spaces. The alveolar walls are perforated by pores of Kohn, which allows passage of bacteria and exudate between alveoli. We will now talk about the physiology of the respiratory system. How is respiration regulated? First is the stretch reflex. The lungs contain stretch receptors innervated by afferent neurons that run in the vagus nerve. When the lung is stretched, the respiratory center in the brainstem is inhibited. This is called end inspiratory reflex. The end expiratory reflex acts similarly. Next are the pressure and chemical reflex. The carotid body and sinus and the aortic body are innervated by the glossopharyngeal and vagus nerve respectively and are located in the bronchial arch. They monitor partial pressure of oxygen and hemodynamic pressure respectively. A decrease in partial pressure of oxygen increases inspiration, while an increase in blood pressure decreases respiration. Let's go to perfusion. Pulmonary blood flow is the cardiac output of the right ventricle and is equal to the cardiac output of the left ventricle. It is about 5 liters per minute at rest. Next, let's discuss pulmonary blood pressure. Pressures are much lower in the pulmonary circulation than in the systemic circulation. Pulmonary arterial pressure averages 15 millimeters mercury compared with aortic pressure of 100 millimeters mercury. Normal pulmonary systolic and diastolic pressure is 20 millimeters mercury and 10 millimeters mercury, respectively. Resistance in the pulmonary circulation is about 1/10 of the systemic circulation. Although pressures in the pulmonary circulation are low, they are sufficient to pump the cardiac output because resistance of the pulmonary circulation is proportionately low. Now let's talk about hydrostatic pressure. It is caused by the weight of a column of fluid that is exposed to gravity and adds or subtracts from the pressure at levels below or above the zero reference plane, respectively. For the pulmonary system, the reference plane is the level of the right atrium, which is at the midline of the lungs. If the lungs are 40 centimeters and the main pulmonary artery pressure is 20 centimeters water, the blood pressure is enough to lift the blood to 20 centimeters above the right atrium. This is enough to perfuse the lung apex even if standing. However, if pulmonary artery pressure goes down to say 15 centimeters water, the lung apex may not be perfused. In the supine or prone position, hydrostatic effects are minimized. Let's proceed to discuss the perfusion zones of the lung. The perfusion zones of the lung depends on the relationship between alveolar, pulmonary arterial, and pulmonary venous pressure. The distribution of blood flow in the lungs is uneven due to the effects of gravity. When a person is supine, blood flow is nearly uniform throughout the lung. When a person is standing, blood flow is lowest at the apex of the lung, called zone 1, and highest at the base of the lung, called zone 3. What are the different zones of the lung? First, zone 1, where blood flow is lowest and normally does not exist in the normal lung. It's when alveolar pressure is greater than pulmonary arterial pressure, which is greater than pulmonary venous pressure. The high alveolar pressure may compress the capillaries and reduce blood flow in zone 1. This situation occurs if arterial blood pressure is decreased as a result of hemorrhage or if alveolar pressure is increased because of positive pressure ventilation. Meanwhile, zone 2 is when blood flow is medium. This is where arterial pressure is greater than alveolar pressure, which is greater than venous pressure. Moving down the lung, arterial pressure progressively increases because of gravitational effects on hydrostatic pressure. Arterial pressure is greater than alveolar pressure in zone 2, and blood flow is driven by the arterial alveolar pressure gradient, not the arterio-venous gradient. It's called the waterfall effect because changes in venous pressure do not affect blood flow until venous pressure exceeds alveolar pressure and we reach zone 3. In zone 3, blood flow is the highest. Usually arterial pressure is greater than venous pressure, which is greater than alveolar pressure. Moving down toward the base of the lung, arterial pressure is highest because of gravitational effects, and venous pressure finally increases to the point where it exceeds alveolar pressure. In zone 3, blood flow is driven by the difference between arterial and venous pressure, as in most vascular beds. The increased hydrostatic pressure causes distension and recruitment of both arteries and veins, decreasing resistance to blood flow. Lastly, Zone 4, where blood flow is reduced and abnormal. It is present when venous pressure is abnormally high, like in left ventricular hypertrophy or mitral stenosis, or in pulmonary edema, which causes accumulation of fluid around the blood vessels. There is vascular coughing due to accumulation of fluid around blood vessels, increasing vascular resistance and reducing blood flow. We will now talk about the different factors that alter pulmonary blood flow. First is that alveolar hypoxia produces hypoxic pulmonary vasoconstriction, or HPV. In the lungs, hypoxia causes vasoconstriction. This response is the opposite of that in other organs, where hypoxia causes vasodilation. Physiologically, HPV is important because local vasoconstriction diverts blood away from poorly ventilated hypoxic regions of the lung and towards well-ventilated regions, balancing blood flow and ventilation. This results from decreased formation and release of nitric oxide by pulmonary epithelium in hypoxic areas, and is potentiated by hyperpnea and acidosis. Fetal pulmonary vascular resistance is very high because of generalized hypoxic vasoconstriction. As a result, blood flow through the fetal lungs is low. With the first breath, the alveoli of the neonatal lungs are oxygenated. Pulmonary vascular resistance decreases, and pulmonary blood flow increases and becomes equal to cardiac output, as what occurs in the adult. Lastly, generalized alveolar hypoxia occurs during hypoventilation or low-inspired PO2, such as when altitudes are greater than 5,000 to 7,000 feet. This increases the total pulmonary vascular resistance, which leads to pulmonary hypertension, increasing the work of the right ventricle. This may in turn result in right ventricular hypertrophy, right axis deviation, and eventually right ventricular failure. Next are changes in lung volume. Pulmonary vascular resistance is minimal when the lung is close to functional residual capacity, or FRC, and increases at both higher and lower lung volumes. The effect of lung volume is complex because two types of blood vessels are involved. First are the extra-alveolar blood vessels, which are the larger distributing arteries and veins of the lung. They are dilated at high lung volumes because of the radial traction exerted on their walls by the alveolar septa. The increased diameter reduces flow resistance. Second are the alveolar vessels, usually the pulmonary capillaries. They are located in the alveolar septa, which are compressed by the enlarged alveoli at high lung volumes. During inspiration, the capillary vascular resistance increases while the larger vessels dilate, increasing their contained blood volume. Next, pulmonary diseases like emphysema and pulmonary emboli obstruct or destroy pulmonary arteries and alters the pattern of pulmonary blood flow, resulting in uneven distribution. Lastly, shunts. Right to left shunts normally occur to a small extent because 2% of the cardiac output bypasses the lung. They may be as great as 50% of cardiac output, like in tetralogy of Fallot. They always result in a decrease in arterial PO2 because of the admixture of venous blood with arterial blood. The magnitude of a right to left shunt can be estimated by having the patient breathe 100% O2 and measuring the degree of dilution of oxygenated arterial blood by the non-oxygenated shunted or venous blood. Next is left to right shunts, which are more common than right to left shunts because pressure are higher on the left side of the heart. They are usually caused by congenital anomalies like patent ductus arteriosus or traumatic injury. They do not result in a decrease in arterial PO2. Instead, PO2 will be elevated on the right side of the heart because there has been admixture of venous blood with arterial blood. We will now discuss ventilation. Alveolar ventilation is not evenly distributed throughout the lungs. Distribution is dependent on the intrapleural pressure gradient, time constant of the lung, and closure of the airways. Interpleural pressure gradient is caused by effects of gravity on the lung within the intact thorax. The cause of interpleural pressure gradient is 1. the density of the lung, which produces hydrostatic pressure difference of 7.5 to 10 centimeter water between the apex and base of vertical lung. 2 is interpleural pressure in a standing adult increases from about 10 centimeter water at the apex to about negative 2 centimeter water at the base. Now, what are its effects? First, regional lung volume varies with changes in interpleural pressure. Transpulmonary pressure is equal to alveolar pressure minus interpleural pressure. Alveolar pressure is zero throughout the lung under static conditions. Therefore, transpulmonary pressure varies from 2 centimeter water at the base to 10 centimeter water at the apex to vertical lung. The difference in transpulmonary pressure and lung volume causes the apex and the base to vary in compliance. Next is tidal volume, which is unevenly distributed in the vertical lung because of the variation in compliance in different sections of the lung. In the vertical lung, most of the tidal volume goes to the base of the lung when respiratory starts at the FRC, is zone 3 where most perfusion normally go. The tidal volume is much more evenly distributed in supine individuals. Now, the time constant of the lung is the product of airway resistance and lung compliance. What is its function? The time constant establishes the range of acinar volume changes. The acinus is the functional unit of the lung. It consists of respiratory bronchioles and all the alveolar ducts and alveoli distal to it. They fill and empty exponentially and not in a straight line. For each time constant, the volume changes 63% towards the equilibrium value. Normally, all acini have equal time constant. Now, what are the effects of diseases? First, the time constant can be unequal because some areas may have low compliance and other areas high resistance. This results in wide variation in regional alveolar ventilation, which produces large differences in the regional alveolar O2 tension and markedly interfere with gas exchange. Now, obstructive lung diseases increases the time constant because of high airway resistance. This leads to slower rate of acinar filling and emptying. Now, dynamic lung compliance is the ratio of tidal volume to change in pleural pressure during the respiratory cycle. This is reduced compared with static lung compliance because the lung has not fully inflated due to the prolonged time constant. Frequency-dependent compliance occurs when lung compliance decreases as respiratory rate increases. Patients reduce respiratory work by breathing more slowly. Longer respiratory cycle allows additional time for pulmonary inflation and deflation to occur. Now, intrinsic positive and expiratory pressure. The patient with high airway resistance do not deflate lung to functional residual capacity. Alveolar pressure remains positive at end expiration. It enhances gradient for expiratory airflow. Now, restrictive lung disease decreases the time constant because of low compliance. This leads to faster rate of acinar filling and emptying, but they undergo smaller changes in volume than normal. The decreased ventilation reduces regional alveolar PO2, resulting in abnormal gas exchange. Lastly, airway closure alters regional alveolar ventilation and increases the work of breathing because high pressure is needed to reopen closed airways. Early airway closure occurs when airways close prematurely when regional transpulmonary pressure falls below a critical level. The causes are as follows. 1. Any process that narrows the airway. 2. Inflammation, excess mucus production, contraction of bronchial smooth muscles, or loss of radial traction on the airways. The ventilation perfusion ratio, or VA over QC, is the ratio of alveolar ventilation, V, to pulmonary blood flow, or Q. Matching ventilation and perfusion is important to achieve the ideal exchange of O2 and CO2. What is the normal VQ ratio? Now, the most efficient gas exchange occurs when the VQ ratio is approximately 1. Normally, alveolar ventilation is 4 to 5 liters per minute and cardiac output is approximately 5 liters per minute, so overall VQ ratio is 0.8 to 1.0. When VQ is 0.9 to 1.0, arterial PO2 is 100 millimeters mercury, and arterial PCO2 is 40 mm mercury. Normally, VQ ratio differs from 0.6 at the base to about 3 at the apex. Now, what about low VQ ratios? It is caused either by inadequate ventilation or excessive blood flow. It causes alveolar O2 tension to decrease. The most common causes are shunts. First are physiologic shunts, which is present when VQ ratio is greater than 0 but less than 1. This is due to low alveolar O2 tension, which results in low PO2 and hemoglobin saturation in blood leaving that area of the lung. When this blood mixes with blood from adequately ventilated area, the overall arterial O2 tension and content is decreased. Next is anatomic shunt, which is present when the VQ ratio equals 0. In unventilated areas of the lung, alveolar O2 tension rapidly decreases until it equals the O2 tension in mixed venous blood, so no further gas exchange occurs. In effect, true venous blood is mixed with oxygenated blood. Anatomic shunt may be intrapulmonary or extrapulmonary, like congenital cardiac anomalies that cause blood flow to bypass the lung. Now, how do you differentiate between anatomic and physiologic shunt? The administration of 100% O2 to a patient with a significant anatomic shunt does not raise arterial O2 tension above 600 mm mercury because the shunted blood is never exposed to the high alveolar O2 tension. In patients with physiologic shunt, due to ventilation perfusion imbalance, administration of 100% O2 raises arterial O2 tension above 600 mm mercury. Normally, only 2 to 5% of the cardiac output is involved in anatomic shunts. Next, high VQ ratio is caused either by excessive ventilation or inadequate blood flow. When the VQ ratio is greater than 1, high alveolar and capillary O2 tension does not result in increased uptake of O2. Very little O2 can be added to the blood because hemoglobin is saturated. Example is alveolar dead space. Alveolar dead space ventilation is wasted ventilation because it produces little O2 uptake. The excess ventilation raises the VQ and alveolar O2 tension above normal. If blood flow to an area of the lung is 0, in other words, VQ ratio equals infinity, then there is no gas exchange in this alveoli and all the ventilation represents dead space ventilation. Alveolar dead space plus anatomic dead space equals physiologic or total dead space. Unless minute ventilation is increased, an increase in alveolar dead space will lead to CO2 retention and hypoxia. In a patient with increased dead space, the initial hypercapnia stimulates respiratory center, increasing minute ventilation so that hypercapnia is resolved but hypoxia remains since there is, in effect, a physiologic shunt. Let's now go to changes in VQ ratio. What are the changes in VQ ratio in airway obstruction? If the airway are completely blocked, like choking on food, then ventilation is 0. If blood flow is normal, then VQ ratio is 0, and this is called a shunt. There is no gas exchange in a lung that is perfused but not ventilated. The PO2 and PCO2 of pulmonary capillary blood, and therefore of systemic arterial blood, will approach their values in mixed venous blood. There will be an increase in the alveolar arterial gradient. Next, what about VQ ratio in blood flow obstruction? If blood flow to a lung is completely blocked, for example, pulmonary embolism, then blood flow to that lung is 0. If ventilation is normal, then the VQ ratio is infinite, which is called dead space. There is no gas exchange in the lung that is ventilated but not perfused. The PO2 and PCO2 of alveolar gas will approach their values in inspired air. Now, what about the VQ ratios in different parts of the lung? Both ventilation and blood flow are non-uniformly distributed in the normal lung. Blood flow is lowest at the apex and highest at the base because of gravitational effects. Ventilation is also lowest at the apex and highest at the base, but the regional difference for ventilation are not as great as for perfusion. Therefore, the VQ ratio is highest, greater than 1, at the apex of the lung and lowest, less than 0.8, at the base of the lung. As a result of regional differences in VQ ratio, there are corresponding differences in the efficiency of gas exchange and in pulmonary capillary. At the apex, with the highest VQ ratio, PO2 is highest and PCO2 is lowest because gas exchange is more efficient. At the base, with the lowest VQ ratio, PO2 is lowest and PCO2 is highest because gas exchange is less efficient. In lung disease, the VQ inequalities are more pronounced than in the normal lung. Consequently, there can be severe hypoxemia and modest hypercapnia. This ends our discussion on the anatomy and physiology of the respiratory tract. See you next time when we discuss obstructive lung disorders.